Good morning, professors on and off the dais. Good morning, my dear friends. I am Purnima Prasad, herself Evangeline Felicia. We are here to present a case. So, demographic details. Name Mr. Rajendran, 45 years old male, who is from Tengasi, who is working as a security, socio-economic scale, lower middle class according to modified Kupusamy scale. Chief complaints, multiple swellings on right lower limb since 3 years, pain in the right lower limb since 6 months. History of presenting illness. Patient was apparently normal 3 years back, and then he noticed multiple swellings over the inner aspect of the right lower limb, which was insidious in onset and gradually progressive. The swellings become more prominent on prolonged standing and decreased on lying down. Pain over the inner aspect of the right lower limb for past 6 months, which is intermittent and dull aching in nature, which is aggravated on prolonged standing and relieved by lying down. No history of prolonged standing was present. No history of itching, pigmentation, night cramps, edema. No history of abdominal distension or chronic constipation. No history of fever, breathlessness, cough and hemoptysis. No history of prolonged immobilization of limb. No history of long-term hospitalization. Past history. No history of similar complaints in the past. No history of abdominal or pelvic surgeries. No, he is not a known case of diabetes mellitus, hypertension, tuberculosis, asthma, COPD or epilepsy. Then family history, no relevant family history. Personal history, appetite is normal, he takes a mixed diet and he has adequate sleep. Bowel and bladder habits are normal. No history of smoking or alcohol. Then summary. Mr. Rajendran, 45 years old male, who is a security by occupation, came to the OPD with complaints of dilated and tortuous veins in the medial aspect of right lower limb for past 3 years, which was insidious in onset and gradually progressive and became more prominent on prolonged standing and decreased by lying down and associated with episodes of dull aching pain for 6 months. From my history, I can conclude this is probably a case of varicose vein involving great saphenous vein. General examination.
Okay, you got to first line.
What's this modified Kupusamy scale?
Sir, we assess the socio-economic status by modified Kupusamy scale. That is, we use the literacy, occupation and income of the person to calculate it.
What is the importance here?
Sir, if the economic scale is lower, accordingly, the treatment also can be managed accordingly to the patient's convenience, sir.
Where is it more important, in varicose veins or in some other problem?
Sir, in tuberculosis and other.
No, concerning with vascular diseases. Varicose veins or
PVD, peripheral vascular diseases.
right, very good. So it's more important in peripheral vascular disease, particularly in TAO and all, because they are usually smokers, they don't take care of their feet properly, they don't even wear footwear, so they are more prone for ulcerations. Right, okay.
Okay, what is the relation between occupation and varicose? Why you are asking this question?
Occupation which is involved in prolonged standing, there is a more they are more likely to get varicose.
Occupation that requires prolonged standing, these persons prone for varicose. Okay, right.
So why does this prolonged standing predispose to varicose?
Sir, if the person is standing for a long time, there will be venous stasis of blood. So it causes chronic ambulatory venous hypertension in the lower limb. So it leads to varicosity.
What is the normal venous pressure in the lower limb?
200.
Sir, in venous, 5 mmHg, and in arteries, it is 32 mmHg, and in capillaries, it is 12 mmHg, sir. It is at rest.
At rest, the pressure should be very low in venous system of the lower limb. But when the patient stands, the pressure equals the arterial pressure. It goes up to 90 to 100 millimeters mercury. But if he walks, the calf muscle pump helps to reduce the pressure. It brings the pressure to 30 to 40 millimeters mercury. But if the patient keep standing for a long period, this high pressure in the veins, they damage the vein walls, valves, and that predisposes the patient to varicose veins. Right.
Okay, you got a second. What type of pain the patient is having?
Dull aching pain, sir.
Dull aching pain. What is
More-
intermittent claudication?
Uh,
What is the difference between dull aching pain and intermittent claudication?
Sir, dull aching pain is like it usually arises in the evening. That is after a prolonged standing only he will complain of pain, sir. But claudication pain is it is like intermittent. It comes and goes.
Claudication pain starts only after walking.
Walking.
Okay. Right. Go to next.
So how do you assess a patient has come to you with a pain in the lower limb? You need to know the etiology. It could be a venous origin, arterial origin, a neurogenic, or even orthopedic. How do you differentiate?
Sir, in case of venous, in case of varicosity, the veins will be dilated, sir. So we will ask the patient to lie down and elevate the limbs. When the limbs are elevated, the tortuosity will, the dilation will be decreased, sir. Whereas in case of arterial
No, now you are in the history. You have to ask the
By
patient.
history, you can differentiate.
pain, sir, if it is neurological, the patient will have the pain will be
Change of posture will aggravate the pain. Hmm? Here there is dull aching pain on prolonged standing.
on.
So see, venous pain, the pain is not felt during the day. It is felt at the end of the day. When he finishes his work, he goes back and have the pain. It is usually dull aching and usually felt in the cough, around the cough. Whereas in arteries, the pain is brought on by activity, walking or climbing upstairs, cycling, anything. That brings the pain. And the pain, the site of the pain is dependent on the level of occlusion of the arteries. Neurogenic pain, the pain is, as the patient starts walking, he develops the pain. And it is relieved by assuming certain postures. He will bend down, so if the pain is due to a sciatica pain, as he bends down, the intervertebral space, this space widens and that relieves the pain. But orthopedic pain is not relieved by anything. If it's due to arthritis or some bony problems, he will continue to have pain irrespective of any measures, except for some analgesics only will relieve the pain. So, and as you said, if he elevates the limb, the pain subsides in the venous pain. But what happens in arterial pain?
It increases, sir.
Why?
Because of it is going against the gravity in artery.
So, already there is insufficiency. So, it has, if he elevates, the blood flow decreases
reduced.
even more, and so the pain will be more. Right. Okay.
Okay, go to next. Why did you ask about itching, pigmentation?
Sir, in case of to rule out arterial disease, no, sir. If the blood is chronic, it is stasis, no, sir. So the blood goes to the extravascular compartment, and there it releases RBCs. So
Because
releasing
of
RBCs
prolonged
causes-
venous hypertension, blood comes out from the capillaries
So
and
hemolysis
irritates the nerve endings. So prolonged itching is due to this irritation. So this is also one of the cause for ulcer also. Okay. Why did you ask about abdominal distension?
secondary causes, sir.
What are the secondary causes?
Tumors,
What tumor?
any
Carcinoma
abdominal,
of stomach.
ovarian tumors,
So pelvic tumor.
pelvic tumors.
Pelvic tumor or fibroid, ovarian tumor, ascites. Right. Why did you ask about breathlessness?
Sir, to rule pulmonary embolism. In case of DVT, it goes and clogs. So, complications, sir.
You asked about fever. Why?
DVT, there is low grade fever.
Is DVT a complication of varicose vein or a cause for varicose vein?
Cause for varicose vein.
Secondary cause.
DVT is a
Cause for varicose.
yes, as a secondary varicose vein can occur due to DVT. So if the patient has already had a DVT, he can have varicose veins. What type of varicose veins will be there in a post DVT patient? What is the system that is involved?
Perforator.
Right, very good. The patient will have perforator incompetence. Post DVT patients will have perforator
Isolated
incompetence. Right.
How many perforators are there?
So there are actually 100 to 150.
Name the perforators.
Named perforators are thigh level, it is Hunterian. Above knee is dot, below knee is buoyed, and cockpit perforators, that is ankle perforators.
May and Kushner perforator.
Mayer custom.
Why did you ask about prolonged immobilization?
So to rule out DVT.
What is E thrombosis?
So in computer using
Prolonged sitting in a
sitting.
computer room, that also cause. What is economic class syndrome?
Sir, in higher jobs, the person
Prolonged air travel. Okay, right. Right.
Long-term hospitalization you asked, no? What is the reason for that?
long-term hospitalization, also the limbs will be immobile, ma'am. So that they will be clotting, that is DVT, more prone to DVT.
More prone to DVT.
Okay. Next slide.
Smoking. Is smoking a risk factor for
Yes,
varicose
sir.
veins? How?
So smoking decreases the collagen production, so endothelial damage will be more. As well as smoking increases the viscosity of the blood.
Right, okay.
Okay.
Next.
Next.
Right, so according to you, at the end of your history, it's varicose veins. But the patient, sometimes the patient may come to you and say, he may not be telling that there is dilated and tortuous veins in my leg.
Multiple swelling.
Yes, then what do you think about?
Sir, it may be multiple lipoma also. But by
If it is having pain, multiple swellings with pain,
pain is mostly due to varicosity.
maybe neurofibromas, lipomas. If he says only swellings, you should also think about a lipoma, neurofibromas and all. But most of our patients, they will be intelligent enough to say that they have got varicose veins, right? So,
How did you confirm that it is from greater venous?
this is not necessary here.
It was in the medial aspect of, inner aspect of the leg, ma'am.
Okay, but
Where the great saphenous vein starts?
Medial end of the dorsal venous arch.
Medial marginal vein. The ends into the
Extends above the medial malleolus and
saphenofemoral junction.
uh,
How many tributaries are there?
6 main tributaries, sir.
6 tributaries. Okay.
right, go to examination. Now you can go to local examination. Yes.
Okay, present.
Inspection, attitude of the limbs was normal. Dilated and tortuous vein seen in front of the medial malleolus, medial aspect of the leg just below the knee, and medial aspect of the thigh along the course of the long subvenous vein. Skin is not stretched and shiny. No pigmentation, eczema, atrophic blanch, corona phlegmaticia, scar, scratch marks, loss of hair, brittle nails. Palpation, no local rise of temperature, no tenderness.
Palpation, and there is no local rise of temperature and no tenderness, and then Roddy's tendon test is And Roddy Stenlenberg test, 1 is positive and it shows saphenofemoral junction incompetence, and 2 is positive and it shows perforated incompetence. And then multiple tourniquet test, it shows above knee and then below knee perforated incompetence. And then modified Perthes test is negative, and Morrissey's cough impulse test is positive, and Fegan's test, and there is depression felt above knee and below knee perforator site, and and then percussion, Swartz test is positive, and examination of opposite lower limb is normal. And systemic examination, abdomen soft, non-tender, no free fluid, and no organomegaly and no palpable masses. And CVS examination, S1, S2 here, and no murmur. And CNS examination, no focal neurological deficit. And RS examination, normal vesical bed sound here. And summary, a 45-year-old male patient who is security by occupation came with complaints of dilated and tortuous vein, and it's along the middle aspect of right leg for 3 years, and it episodes of dull legging pain, and for 6 months. And examination, modified Perthes test is negative, and Roddy Stenlenberg test indicates saphenofemoral junction incompetence, and multiple tourniquet test indicates above knee and below knee perforated incompetence.
Okay, you got to inspection.
Now here you have mixed the venous examination and arterial examination. You can do the venous examination first, then mention some points to rule out that there is no arterial insufficiency. That would have been better. Okay. So what are the things that you will look for the venous pathology here in inspection? You got dilated veins on the medial aspect, right? Then what are the other things?
So pigmentation, and then coronophlebectasia, and scar, and
right.
flat
So
marks.
okay. So those things. Then mention separately the next thing: the skin, stretched skin, shiny skin, loss of subcutaneous fat, loss of hair, nails, brittle nails. All these things to rule out that there is no arterial insufficiency. Why are you bothered about arterial insufficiency here? You have got a varicose veins. Why do you need to know about
Treatment,
arterial?
if we put bandage, we should not put the bandage in arterial insufficiency.
So only for bandage.
Then treatment also in prescribing drugs.
For everything, not only for treatment. Even what do you mean by guttering of veins? Where does it happen?
In arterial
Yes, in arterial insufficiency, there is loss of subcutaneous fat, the skin is stretched, so the veins are more prominently seen. We might, even the patient will come to you saying that he has got a varicosities, and we will also at first sight we will think that it is varicosities, but when you go into examination, we will find out that it is arterial insufficiency that is causing all the problems. So not only for treatment, you have to differentiate the exact cause for the pain. Okay, so you need to know whether there is a arterial insufficiency also, right?
So what is the definition for varicose?
Sir, it is a dilated, elongated and tortuous superficial veins of the lower limb, which is
How many superficial veins are present in the leg?
long saphenous vein,
And
short saphenous vein.
how many percentage of blood is drained by superficial vein, and how many
20%,
percentage by the,
sir.
how many percentage by the deep veins?
Deep percentage 80%, superficial is 20%.
80
sir.
to 90 by the deep veins,
10 to
10%
20.
by the superficial. What is direct perforator? What is indirect perforator?
Direct perforator, it connects the superficial vein to the deep vein directly, whereas in indirect perforator, it connects to the muscles, sir. It perforates.
Okay.
What is a perforator? What is a communicating vein?
So perforator connects to the superficial vein, sir. Whereas in
perforator connects deep and superficial.
whereas in communicating, it is like
Connects two perforators, two superficial.
Same system of veins. See, deep veins,
superficial
you have two divisions along the same vein. So it could be the perforator is for connection between the superficial
and
to
the
the deep veins. Communicating
thread
veins is for the same system, right?
Sir?
What is thread vein?
It is malleolar.
If the size is
flap.
less than
Less than
0.5 millimeter, it is thread. Reticular varices?
1 to 3, 2.9.
2.9. Okay. Why did you ask about loss of hair, brittle hair?
Sir,
These are all the signs of arterial
Arterial.
insufficiency. Okay. Go to next. What is Brody Trendelenburg test? How to do?
So we should ask the first we should make the patient to lie down, and then we should milk the veins, and then we should tie a tourniquet at the below the saphenofemoral junction, and then
You elevate the limb first.
yes, sir.
Ask the patient to lie down, then
Then
you
elevate the
elevate,
limb
then
and to
empty
milk
the
the
veins. Then
And then we should tie the tourniquet below the saphenofemoral junction, and then we should ask the patient to stand immediately, and we should release the tourniquet, and there is rapid filling of blood from above, and we show saphenofemoral junction incompetence, sir. And in 2 perforator we can see, and here we should remove the tourniquet. Here we should not remove the tourniquet, so we can see gradual filling of blood from below.
gradual filling below means perforator incompetence.
Perforator, and
Rapid filling
flow
above
from
means
above means,
saphenofemoral incompetence. Okay, right.
Why you want to elevate the limb?
Ma'am, to milking the veins to empty the vein. Empty the
Before
vein.
tying the tourniquet, vein should be empty.
Empty the vein.
Only you should tie the tourniquet.
Okay, next slide. What is modified Perthes?
So to rule out DVT, we can do this
How to
test. Here we should tie the tourniquet at the level of the incompetence, and we should.
Difference between Trendelenburg and modified Perthes.
So, ma'am, this is to rule out DVT, and that is to rule out saphenofemoral junction incompetence and perforator incompetence, ma'am. Here we should tie the tourniquet at the incompetence, and then we should ask the patient to walk or exercise, and if the pain felt or the the vein dilated, we can see that is DVT is present, ma'am. Yes, ma'am, milk. But here we should not milk the vein.
This is mainly for to identify the deep vein thrombosis. Modified Perthes. What is Fegan's test?
Then Fegan's here we can see the blowouts in the perforator.
First you ask the patient to stand.
Stand.
Then you mark the point where the blowouts are seen. Then you ask the patient to lie down.
Lie down.
Then you palpate along the course of the veins. You can see the dippings.
Dippings.
That indicates the perforator incompetence.
Ma'am, because of the perforator dilated, and this will stretch the deep fascia, so we can see blowout deep fascia.
So in modified Perthes test, you will be asking the patient to go for a walk, no? What type of walk you will ask the patient?
Ma'am, vigorous exercise.
Brisk walk. You should ask the patient to go for a brisk walk. Then that only will elicit the pain. If the patient complains of pain, that indicates it is probably due to
Yes, deep in the
deep pain.
So basically you have how many tests for saphenofemoral junction incompetence? What are they? Trendelenburg 1.
And then Morrissey's cough impulse test. And then Schwartz test.
How many tests for DVT?
DVT, the 2 tests, sir. First it is modified Perthes test, and then
Perthes test. Perthes test we don't do, but modified Perthes test. The other 2 Homan sign, Moses sign are not done.
Homan sign.
Right. How many tests are there for perforator incompetence?
Sir, first one is Brody Senthil test.
Test 2, Brody Trendelenburg 2.
And then Pratt test and Fegan test.
One multiple tourniquet test. How many tourniquets do you apply in multiple tourniquet tests? 4. Right. So you have to complete these tests and find out where is the level of incompetence. Right.
What is the purpose of tying multiple tourniquets to identify? What is the purpose of using multiple tourniquets in the test?
To find the site of perforator, which perforator is incompetent.
So that should be tied in between the
Between the two
perforators.
perforators.
So identify the site of perforator.
Right. Next.
Next.
Okay. Go to the diagnosis. Yes. C2, EP, ASP, and PR. So what does that mean?
What is CEAP?
Clinical,
Etiological,
etiological, anatomical, and pathological.
Pathological. Here there is no complication.
Yes, sir. No complication.
Only varicose vein.
Right.
In this case, is it, did you see the veins in the thigh?
Yes. Yes, ma'am.
Yes, you saw the veins in the thigh also.
It's not prominent by while doing the test.
After tying the tourniquet, you saw the vein in the column in the thigh also.
Here there is no ulcer.
No, ma'am.
Suppose ulcer is present, what is the site? What is the exact site?
Medial malleolus.
Why? It is otherwise called as
Hiatus area.
hiatus area. How to differentiate venous ulcer from the arterial ulcer?
Sir, venous ulcer will be shallow, whereas arterial ulcer will be deep,
Yeah.
and this is painless, that is painful, and it will have sloping edge, whereas that will be
Venous ulcer occurs just above the medial
Medial
malleolus.
malleolus.
It is
Arterial
vertically oval in shape, shallow ulcer, sloping edge. It will not penetrate the deep fascia. But arterial ulcer usually occurs behind the pressure points. So it can extend up to any level.
bone
Venous ulcer is a painless ulcer. Arterial ulcer, painful ulcer.
ulcer.
Okay, right.
So what do you do next? How do you proceed?
Investigation.
What is duplexan?
So Doppler plus B mode scan.
B mode ultrasound. Okay.
What's the advantage of a duplex over a Doppler?
Sir, in Doppler only the blood flow can be determined, sir. Whereas in duplex, the reflex, incompetence, backflow, everything can be determined.
So, what is reflex? What do you mean by the term reflex?
Reflex is like reverse flow.
Where do you see for the reverse flow? So, saphenofemoral junction, if there is a reversal of flow, it should be from superficial to deep. If there is a reversal of flow lasting for more than 0.5 seconds, that is called this reflex is there. That is the commonest cause for a saphenofemoral incompetence, right? So,
Why you are doing ultrasound?
Secondary causes, sir.
To rule out the secondary cause. Okay.
right, what are the information that you get from duplex? You said reflex is one, then
Perforator, site of incompetence, sir.
right, then so whether saphenofemoral junction incompetence is there, long saphenous vein incompetence, then
Even for
perforators
DVT.
and the levels of perforators, but more importantly we will look for DVT.
DVT.
Why do you want to look for DVT?
Sir, if the patient is having DVT, then he is contradicted for surgery in varicose
So,
vein, sir.
all forms of intervention are contraindications for if the patient has a DVT.
DVT.
So, if a patient with a DVT, the treatment is going to be mostly conservative, right? So,
In this patient, you have given treatment as treadle back surgery. Why? This patient is not having any complication. No?
Sir, like
do you need to operate all varicose veins, or is there any indication for surgery in varicose
pain,
vein?
he was having dull aching pain. He was symptomatic, ma'am, so that we go for surgery.
Right,
If it
good.
is same symptomatic.
Right. So, what are the other complications of varicose veins?
Pigmentation, eczema, bleeding, first of all bleeding, then cosmetic problem.
So, what will you do if you are examining the patient? He suddenly starts having a bleed. Have you seen a varicose vein
Elevate
bleed?
the limbs.
Elevate, then
Compress.
then apply a compression bandage, right? So it will, since these veins are under high pressure, it will be like an arterial bleed. He will have a torrential bleeding. So you have to first identify the site, compress, elevate, and apply a compression bandage, right?
Okay, stripping should be done up to
Above the knee level.
Upper
Because-
part of the leg. Why?
Below the knee there is there
There
will
is
be
a chance of injury to the
injury to the nerves.
saphenous nerve. Right. Suppose patient don't want surgery. Any conservative management?
Sir, Viscous conservative
Viscous maneuver. That is
elevation,
Elevation,
education,
exercise.
compression bandage.
compression bandage. Okay. Patient is having venous ulcer also along with this. How to manage?
Compression
Will you do
bandage.
surgery or not?
No, sir.
Why?
First, start
If you do surgery, the ulcer will heal fast. There is no contraindication for doing surgery.
Ulcer, is it a complication or not?
yes.
So
ma'am.
you said
It's a
all
complication.
complications are indications for surgery. Pain is a subjective thing. So you are opting for surgery for pain but not for ulcer. Hmm? So ulcer, what are the other complications? Ulceration, pigmentation.
eczema, bleeding, lipodermatosclerosis.
What is that?
So, fibrosis of the skin and subcutaneous tissue. So there will be obliteration of the fat and
That leg is called as
woody leg,
woody leg or champagne bottle leg.
inverted champagne bottle.
What's the cause for pigmentation?
So hemosiderin release because of
Where it is coming?
RBC lysis. In extravascular compartment releases hemosiderin. It causes pigmentation and eczema.
Name some sclerosants.
What is the cause for itching?
Hemosiderin deposition.
Okay. Hemosiderin deposition
The
is
nerve
there.
endings will be
Irritated.
What is the treatment for itching? If the patient complains of itching, how will you treat? There will be release of histamine, no? From where histamine is coming?
Antihistamines will give.
From where histamine is coming?
muscle.
Yes. RBCs, WBCs, everything will be there outside the vascular compartment. It is outside. So that is also released, dying, and because of that only itching is.
Right. What is sclerotherapy?
It is like combining air and foam, 1:4
That is
ratio.
foam sclerotherapy. I am asking sclerotherapy.
Sclerosants, using sclerosants.
Name some sclerosants.
Sodium
Sodium tetradecyl sulfate, and then polidocanal, and sodium marvate, and
5% phenol in almond oil.
almond oil.
How to inject? Before injecting sclerosin, what precaution you should take?
elevate the veins and milk
You empty the veins first, then
empty the veins and mark the inject
inject
in the
directly
sides
into
of-
the vein. You should not pierce the vein wall. Okay. After applying sclerosin, what should be done?
compression bandage should be given.
What is the mechanism of action of sclerosin?
It will collapse the vein.
It causes aseptic inflammation inside the vessel wall, thereby it occludes a lumen. What are all the complications of sclerotherapy?
Thrombosis and recurrence.
Extravasation leads to eczema, embolism. What is microsclerotherapy?
0.1 ml of
Sclerosin is injected, that is for small veins. Foam sclerotherapy,
air and foam is mixed in 1:4
you make a foam by injecting
foam and air.
air and sclerosin. Okay, the action is also same, right? What is hook blephectomy?
So by using mosquito forceps, we will
You make a small stab incision, then pull out the vein by hook and cut it. Right. What is the treatment for perforator incompetence?
Sir, subfacial endothelial ligation.
Ligation or multiple blephectomy. Okay. What is the latest treatment?
Components of indolent breast surgery.
plus ligation of the
So, near
to ligate the vein and it
to
You lie
prevent
at the
safina
point
varix, ma'am.
where it enters into the femoral vein. Suppose if you leave a small portion, there is a chance for
Safina varix.
safina varix. Okay, right.
Before ligating the junction,
Ligate the tributaries. Should be ligated.
What is the latest management?
Radio frequency ablation, endovenous
laser ablation.
Laser ablation. Okay.
What is the mechanism in radio frequency ablation? How it is causing?
Here it emits radio frequency waves and it causes thrombosis and collapsing of the vein. That's 120 degrees Celsius
Thermal, it is a type of thermal ablation.
thermal ablation.
Okay, nice presentation.
Thank you.